Welcome to our comprehensive lecture on gastroenteritis for primary care physicians. In this video, we will explore the etiologies, pathophysiology, clinical features, diagnostics, and management strategies that every physician should know. Gastroenteritis remains one of the most common conditions worldwide, with viral etiologies at the forefront. Norovirus and Rotavirus lead in many outbreaks, whereas bacteria like Salmonella, Shigella, and certain E. coli strains also contribute significantly to morbidity. Let's take a closer look at these various pathogens and their distinct features. The inflammatory process in gastroenteritis depends on the pathogen's mechanism of action. Viruses commonly damage intestinal epithelial cells, causing malabsorption, while certain bacteria produce toxins that increase fluid secretion. Understanding these mechanisms guides our treatment strategy. Clinical presentations vary widely, ranging from mild watery diarrhea to severe bloody diarrhea, with or without vomiting and fever. Keep an eye out for dehydration signs, dry mucous membranes, decreased urine output, tachycardia, and orthostatic hypertension. The differential diagnosis is broad. Not every acute abdomen or diarrhea is caused by gastroenteritis. Ruling out conditions like appendicitis and inflammatory bowel disease is crucial, particularly if red flags like severe localized pain or chronic bloody diarrhea arise. A thorough history, physical exam, and targeted laboratory tests will help isolate the cause. Stool cultures, ova and parasite tests, antigen detection, and fecal leukocyte evaluation can pinpoint the organism. Don't forget to check CBC and electrolytes to gauge the severity and dehydration. Rehydration is the cornerstone. In mild to moderate cases, oral rehydration solutions may suffice. In severe dehydration, intravenous fluids are essential. Monitor electrolytes, especially potassium levels, and replace as needed. Antiemetics like ondansetron or metoclopramide can ease nausea and vomiting, while antipyretics such as acetaminophen or ibuprofen alleviate fever. Use antimotility agents like loperamide judiciously, avoid them in bloody or suspected invasive diarrhea. In confirmed or high suspicion bacterial gastroenteritis with severe symptoms, antibiotic therapy is warranted. Common regimens include ciprofloxacin 500 mg PO twice daily for 3 to 5 days, azithromycin 500 mg PO daily for 3 days, metronidazole 2G once daily for 5 days in Giardia, nitazoxanide 500 mg PO twice daily for 3 days in Cryptosporidium. Always tailor therapy to local resistance patterns and patient characteristics. Children, the elderly, and immunocompromised patients are at higher risk for complications. Keep a close watch on hydration status in children. Elderly patients often have comorbidities that can worsen outcomes. Immunocompromised individuals may require more aggressive workups and treatments. Prevention is better than cure. Promote consistent hand hygiene, proper food handling and cooking, safe drinking water, and appropriate vaccinations such as the rotavirus vaccine for children. Mild cases of gastroenteritis often resolve without patient care and proper hydration. Severe or complicated cases may require inpatient monitoring. By following these best practices, we can ensure efficient, high-quality care. Thank you for watching this comprehensive lecture on gastroenteritis, your one-stop resource for diagnosis and management in primary care. Please like, share, and subscribe for more medical lectures.